We'll start with yes, Dr. Paul Phillips.
All right, so for those of you who are not sure, the answer is indeed yes. I have no financial interests or relationships to disclose, and there is no question I would treat this child. Although I would not say it's malpractice to observe some cases, I will explain why I've recommended treatment for all cases I've encountered in the past 21 years of my practice. Now, I am going with the assumption that the workup and presentation is consistent with an autoimmune optic neuritis, as in the case presented here, and that there are no severe contraindications. We're not talking about a patient in diabetic ketoacidosis. Now, I know Dr. Liu will bring up our only randomized prospective mass study of steroid treatment in optic neuritis, the ONTT, the Optic Neuritis Treatment Trial, but that, of course, was in adults. And that trial did indeed show that although high-dose steroids increased the rate of recovery, it did not improve final vision compared with no treatment. However, we know children are not adults. That's why we're in the pediatric ophthalmology session here, and that they often present, when they have optic neuritis, with severe visual loss, bilateral disc edema, and have a lower risk of multiple sclerosis. So other things are going on. And on top of that, autoimmune optic neuritis is a heterogeneous group of disorders. In addition to those associated with multiple sclerosis, we have the entity of neuromyelitis optica, so-called Devick's disease, and the new kid on the block, MOG IgG Optic Neuritis. Now, we all know neuromyelitis optica is a severe autoimmune disease. It can affect the optic nerve and spinal cord. It can be monophasic or relapsing remitting. We now have a serologic test, the acroporin 4 test, and we know these kids will often have severe visual loss that is often permanent. And these kids can present with an isolated unilateral optic neuritis, such as the case presented here. And the recommended treatment is early treatment, aggressive steroid, often with plasma exchange. And retrospective studies have shown a better outcome with early intervention. Now, the new kid on the block I mentioned is the MOG-positive optic neuritis. This is actually defined by a serologic test, the myelin oligodendrocyte glycoprotein antibody. And we're still learning about it. It encompasses a wide range of patients, but it is more common in children, up to 40 or 50% of cases, perhaps. There's an equal gender distribution, and although it might be associated with acute disseminated encephalomyelitis and transverse myelitis, it may also present as an isolated optic neuritis. We know that these patients often have severe visual loss at onset, 50% bilateral, often with severe disc edema, peripapillary hemorrhages. However, even some of these may present as an isolated unilateral optic neuritis, even without disc edema. The treatment recommended, these kids often, they have severe visual loss, 6 to 26%, depending on the series, and they often have a recurrent steroid-responsive optic neuritis. So the current treatment is actually pretty aggressive. From John Chen's studies, 5 days of IV Solumedrol, followed by a prednisone taper over several months. And in addition, proceeding to IVIG or plasma exchange if the visual loss is either severe at onset or if there is poor recovery. So, why do I recommend treatment? All of these patients may present, these children, with an isolated optic neuritis. Clinical findings do not allow a definitive distinction at presentation. Serologic testing, such as acroporin or the MOG, is not available for several days to a week, and a delay in treatment could result in worse outcome for some, certainly with NMO and possibly even MOG. So unless you have one of these, this is our clinic will not buy one, a crystal ball. There's just no way of distinguishing how these children will, the outcome. Now, some will say, what about the child with mild visual loss? Why not just watch some of those? Well, I presented the case I just saw a month ago. 12-year-old boy came in 2040. We recommended treatment. The family declined. His vision over the next day or two went down to 2400. We then treated him with steroids and plasma exchange, but there was no improvement. And he subsequently had a positive NMO test. So once again, even with mild visual loss, some children will lose vision during follow-up. It is not possible to know which ones will lose vision. If this is your child, are you just going to sit and watch? Nothing good happens to optic neurons as visual loss occurs. And you want to prevent a disc edema from evolving to the severe pallor, a graveyard to an optic nerve. So, unless you have a crystal ball, do not fiddle while Rome burns. Put out the fire, treat with steroids. Thank you.